All right, welcome back to The Explainer. Today, we're diving into one of the absolute highest stakes, rapid fire clinical challenges in all of medicine, diagnosing acute aortic syndromes. Picture this, you're in the ED, the clock is ticking, the pressure's totally on, and a patient rolls in with severe chest pain. Now, your brain is probably going to immediately jump to a heart attack, right? But what if it's actually something structurally catastrophic happening to the largest blood vessel in the body? We're going to decode the ultimate diagnostic roadmap for acute aortic dissection, focusing specifically on how the ADGRS score can totally guide your diagnosis. So here's the frankly terrifying reality about an aortic dissection. It is the ultimate great masquerader. Looking at the comprehensive ICU guidelines we're reviewing today, a dissection can literally perfectly mimic a myocardial infarction, or a PE, or even heart failure, syncope, maybe just isolated limb ischemia. Think about it. If the inner lining of the aorta tears and blood just surges into that middle layer, creating a false lumen, the symptoms are going to depend entirely on which branch vessels happen to get choked off in the process. Because it mimics so many other common emergencies, diagnosing this killer requires an incredibly high index of clinical suspicion. Seriously, if you aren't actively looking for it, you're going to miss it.
Okay, let's dive into this. How do we actually spot the difference just by talking to the patient? Well, a classic MI usually presents with a crescendo pattern, right? The pain slowly builds up over minutes. Aortic dissection pain, on the other hand, is a complete 0 to 100 phenomenon. It's abrupt, it's maximal right at the very onset, and patients will often describe it as this sharp, tearing, or ripping sensation in their chest, back, or neck. But, and this is a massive caveat from the guidelines, the absence of pain doesn't entirely rule out a dissection. Some patients, especially if they have certain neurological complications or syncope, well, they might not report any pain at all.
Because the presentation can be just so chaotic, we need a reliable system to cut through all that noise. So enter the ADRS, or the Aortic Dissection Detection Risk Score. You can think of this as your bedside detective's checklist. It takes this massive array of potential symptoms, patient histories, and physical findings, and it brilliantly chunks that risk into 3 distinct, super easy to evaluate categories. By just figuring out how many of these 3 categories are positive, you can rapidly triage your patient's pre-test probability for a dissection. And that score? It's going to precisely guide your entire diagnostic path. Let's break down that first category of the ADRS. This one focuses entirely on pre-existing vulnerabilities. We're talking high-risk conditions. Basically, we are looking for structural weaknesses in the aorta that were there before the patient even walked through the hospital doors. Think about conditions where the collagen or elastin in the blood vessels is just inherently faulty. Stuff like Marfan syndrome or other connective tissue disorders. We also definitely have to flag anyone with a family history of aortic disease, known bicuspid aortic valve disease, a known thoracic aneurysm, or any history of recent aortic manipulation. Like a recent surgery or a cardiac cath. Now, shifting gears to the active presentation. Category 2 isolates the high-risk pain features. If your patient is currently experiencing chest, back, or abdominal pain, you've got to drill down into the exact characteristics of that pain. Is it abrupt in onset? Is it extremely severe in intensity? Does it have that classic ripping or tearing quality we talked about? If any of these specific, severe descriptions are present, boom, Category 2 is positive. This is what helps immediately raise those red flags and helps you differentiate this from your typical dull, heavy acute coronary syndrome. And finally, we have Category 3, which covers the high-risk physical exam features. This is where we're looking for tangible physical evidence of a perfusion deficit. You see, when that false lumen expands, it can literally crush branching arteries. If it happens to block the subclavian artery, you might find a pulse deficit or a really significant systolic blood pressure difference between the left and right arms. If it blocks a spinal or cerebral artery, you're going to see a focal neurologic deficit. You might even hear a brand new aortic regurgitation murmur if the tear tracks backward into the aortic valve, or the patient could just be in full-blown hypotensive shock. But listen, you have to remember this absolutely crucial limitation. These exam findings are highly specific, sure, but they are not very sensitive at all. In fact, they're only present in about 25% of cases, so you simply cannot use a completely normal physical exam to rule out a dissection. So, the crucial point is how we actually synthesize all this information to actively guide our diagnostic path. The ADRS gives you 1 point per category present, not per individual symptom. It acts exactly like a triage funnel. If your patient scores a 0, they fall into the low pretest probability bucket. If they score a 1, meaning they have any single category present, they've got a moderate probability and need a targeted evaluation. And if they score a 2 or 3, meaning they've got high-risk features across multiple categories, well, they have very high pretest probability. For those patients, you need to be arranging expedited aortic imaging immediately, unless, of course, an acute coronary syndrome is definitively more likely.
Seeing this all put together brilliantly illustrates the full AHA and ACC diagnostic algorithm in practice. The flow makes so much sense. If your patient has an ADDR score of 1, your very first step is to check an ECG. Why? Well, to see if it's consistent with a STEMI, mostly because a primary acute coronary syndrome is just statistically way more common. But if that score is a 2 or 3, the protocol completely shifts gears. Especially if they have a perfusion deficit, you are bypassing all those routine delays. You're triggering an immediate surgical consultation and getting that expedited imaging set up right away. The algorithm literally forces you to act decisively based on that exact risk tier.
But hey, what about those low-risk patients? Well, this brings us to a really exciting update from the recent guidelines. For patients who score a perfect 0 on the ADDRS, you can now actually use a high-sensitivity D-dimer test to safely rule out a dissection. If their D-dimer comes back under 500 nanograms per milliliter, this combined approach has a massive negative predictive value. It safely prevents unnecessary CT scans, saving the patient from all that radiation and nephrotoxic contrast, not to mention saving the hospital a ton of time and resources. But, and please hear this massive warning loud and clear, a D-dimer should absolutely never be used alone to rule out a dissection in your moderate or high-risk patients. No exceptions. Okay, so once you've decided imaging is definitely required, you've got to choose the right tool for the job. An ECG-gated CT is basically the most widely available, highly sensitive go-to choice, assuming your patient is hemodynamically stable. It gives you a great look at the entire aorta from the chest all the way down to the pelvis. But what if your patient is hypotensive and actively crashing? You obviously cannot send them down the hall to the CT scanner. In that scenario, transesophageal echocardiography, or TEE, is hands down your preferred modality. It's done right there at the bedside, uses zero radiation, needs zero contrast, and it's still 98 to 99% sensitive for diagnosing a dissection. Now, an MRI is technically the most accurate option out there, but let's be real, it's just far too time-consuming when you're in the acute emergency phase. Now, what's really interesting about this slide is that once imaging actually confirms the dissection, we arrive at the absolute golden rule of aortic dissection pharmacology. Before that patient even rolls into the operating room, you have to tightly control their hemodynamics to prevent that tear from propagating further. The rule here is simple, it's totally non-negotiable, and it is absolutely life-saving. Beta blockers first. Always. Let's break down the deadly physiology behind why this rule exists. You see, the propagation of an aortic tear is driven by shear stress on the vessel wall. If you want to get mathematical, it's dP/dt, the change in pressure over time. If you make the mistake of giving a patient a vasodilator first to just try and bring down their blood pressure, their body is going to respond with a reflex tachycardia. The heart will suddenly start pumping faster and way harder. That drastically increases the shear stress and will literally rip the aorta further apart. So how do we prevent that nightmare scenario? Step 1 is always an IV beta blocker, like esmolol or labetalol, to really clamp down that heart rate to under 60 beats per minute and blunt the sheer force of contraction. Step 2 is aggressive pain control using IV opiates, which naturally helps to lower that sympathetic drive. Then, and only in step 3, after your beta blockade is completely, firmly established, can you introduce an IV vasodilator like nicardipine, and that's only if the systolic blood pressure is still hovering over 120. As we wrap up this explainer, I really want to leave you with a provocative question, just to test your clinical intuition a bit. Let's say your patient's ADDRS is a flat 0. Their D-dimer comes back comfortably under 500. By the book, the guidelines tell you that you can safely rule out an acute aortic syndrome. But as you're standing right there at the bedside, the patient tells you their pain is kind of subtly shifting. Maybe it's migrating just a bit down their back. So what is your next move? Look, these algorithms are absolutely brilliant tools to structure our thinking. They prevent us from missing the great masqueraders. But the guidelines themselves also explicitly state this. A normal D-dimer or a low score does not completely rule out the disease if your clinical suspicion remains high. Ultimately, your algorithms are there to guide you, but your clinical intuition and your unyielding vigilance, those have to remain your ultimate guide. Keep your eyes open out there and always trust your gut.